So we're going to look at a few different populations in this second sort of 45 minutes. The first one is pain, and they're all going to be very brief. I apologize. It's going to feel a bit like a rush. We're going to do pain at pregnancy, benzodiazepines, and then harm reduction. So if you have questions, please pop them in the chat along the way, and I'll stop at certain points in time and answer a couple of them and try to keep us moving on schedule. So if we look at pain, there is the most frequently referred to definition is from the International Association for the Study of Pain, or IASP for short. They define pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in such terms. And so we sort of balance that with the very subjective nature of pain and the limited understanding we have of it. So going back really to the notion that pain is really what the person is experiencing and how they describe it, what they say they're describing. We still don't have any really objective ways of measuring pain or trying to quantify it. We have some scales we can use, but we're very much focused on the patient's experience and their description of the pain. So in terms of defining chronic pain, it's currently described or defined as pain that lasts greater than 3 months, or perhaps shorter, depending on the mechanism of injury, and longer than tissue healing or expected resolution is sort of a key piece in terms of defining something as chronic. It's not always constant. Sometimes it's recurrent with periods of remission. And a lot of the mechanisms underlying acute and chronic pain are very difficult to explain or describe. We don't fully understand them. And some of the things that we do understand are extremely difficult to explain to patients, and sometimes even just difficult for us to understand because it's so complicated. The treatment of pain is most definitely not restricted only to the use of opioids. Ideally, it's multimodality. In terms of the prevalence in Canada, it's quite significant. We have StatsCan data showing us that about a third of Canadians have at some point experienced moderate to severe pain, and smaller subsets of those patients experience daily pain and some even constant pain. So when you compare it to other prevalent conditions such as diabetes, asthma, cardiovascular issues, it's actually more prevalent than those. It's sort of a bit of a hidden problem. In terms of comorbidities or consequences or sort of effects of pain, there's a lot of concurrent mental health issues. There's a lot of sense of isolation that others don't understand what the person may be going through because you can't necessarily see the problem. The problem may not be apparent from looking at someone just from the outside. There's a lot of functional effects in terms of occupational functioning. A lot of patients with chronic pain unfortunately end up not being employed or not fully employed. And with the pain and certainly with the concurrence of the mental health issues, there's an increased risk of suicide that's quite significant in this population as well. So in patients with opioid use disorder, kind of throws another whole wrench in the experience of pain, in that patients who, and this goes for patients who don't just have opioid use disorder, but it's particularly severe in them. We kind of describe our patients as having a low tolerance for pain and a high tolerance for opioids. So some of the opioid effects that we see in chronic pain patients include hyperalgesia, allodynia, changes in the way they perceive pain, such as it's actually worse than someone who's not on chronic opioid therapy. And these seem to be magnified in patients who have uncontrolled opioid use furthermore. So we also know that the undertreatment of pain, whether it's in the population of patients with addiction or not, is associated with patients not staying to complete treatment, leaving against medical advice. Definitely not as good outcomes as when it's properly treated. So if we look back to Adam, who had quite a long history of opioid use and misuse and addiction, and let's say we've stabilized him nicely on methadone, but then unfortunately has a motor vehicle crash, not at all related to substance use. our patients, are at risk for all the things that the general population might be at risk for as well. And we get a call from, perhaps it's the orthopedic surgery resident, perhaps, and more commonly, it's probably the hospital inpatient pharmacist who's kind of doing the med reconciliation and sees that there's methadone there, is calling to find out about last dose, information about how many carries, things like that is the best practice. And once they relay the history, either to you as a pharmacist, or maybe they've managed to track down the prescriber, they sort of describe what's happened. There's been, had to have some surgery for fractures, obviously the pain related to broken bones. And once they confirm the doses, they say to you, okay, that's great. We'll just put him on his regular methadone and everything should be fine. At which point you say, please don't hang up the phone. The fact they're putting him back on his methadone is amazing. In the past, that used to be much more of a struggle. It seems to be generally pretty smooth these days, that they'll make sure that someone will prescribe the methadone and they'll figure out the dose and appropriately, as long as not too many have been missed, continue that. But the key here is that the patient is going to need other pain control beyond the methadone, and sometimes in higher doses to sort of overcome the tolerance that they have to the methadone, which is a bit counterintuitive to what a lot of people think is sort of happening with our methadone patients. So ideally, we would use other non-opioid ways of managing the pain. So that could be NSAIDs, that could be, regional blocks for surgery, or even post-op pain with a PCA, not with a PCA, but with, ongoing nerve block, using some of the local anesthetic agents. Occasionally, we might increase or split the methadone dose. Sometimes we might add other opioids. If we're going to add other opioids, we're going to usually have to use the sort of high affinity, more potent ones, such as fentanyl and hydromorphone. And that's certainly the case with buprenorphine, in order to overcome how tightly bound it is to the receptor. Ideally, we want to give the patient, in terms of outpatient prescriptions, short prescriptions, frequent dispensing, so that there's external controls over the opioids, so that there's not such a risk of them having issues with misusing it. Ideally managed by one prescriber, so that someone can be manipulating the methadone dose at the same time as they may be changing around the dose of the other opioid, and also just having a good awareness of any misuse of either. And we tend to have a bit more of a kind of structured approach to opioid prescribing, let's say, than sort of the average physician who's not involved in OAT. Most patients who are stable will generally not want to use their previously abused opioid, because they know that it could trigger some cravings, it could trigger some use. So often, if they previously used oxycodone, we'll pick something different. So that could be an important consideration. All right, so let's see who's still with me. So this is a pre-booked surgery situation, not sort of an emergent one. Okay. So in general, the sort of easiest thing to do is to continue methadone at the same dose. And we just actually, last year, there was a group at Toronto General that published guidelines with respect to perioperative management of buprenorphine. They came out with the same recommendation, and mostly it's because it's the simplest one. And we're not going to be at risk of people really trying to mess around with the methadone dose and sort of inadvertently destabilize the patient. So that's sort of the best general answer across the board. And we don't see people taking people off methadone anymore like we used to, which is good. All right. Another, oh, my apologies. we talked a little bit about divided doses, and let's see what your thoughts are on these scenarios. And you can select more than one. Okay, I'll give you a few more seconds. All right, so these are all potential situations where we might divide doses. We've talked about pain in terms of divided doses. Methadone's duration of analgesic action is similar to morphine, sort of 4 to 6 hours. So sometimes patients might even need up to QID dosing. Rapid metabolizer we touched on already. Usually that would be BID. Sometimes patients that are on inducing medications, that's rare, I find, but occasionally that may come up, and we'll talk more about pregnancy in a short while. So as we look at what else can be done for pain, there's so many things. Unfortunately, many of them are not covered. So it really depends on the patient's ability to pay. But in an ideal world, we would use medications, and we would use some of these strategies depending on what type of painful condition we would be dealing with. So if we go back to Joyce, so she ends up, as you remember, on buprenorphine after she was in jail, and she brings in a prescription. She's stable. She brings in a prescription for hydromorphone from her GP and says the sort of classic, like, my GP knows that I'm on buprenorphine, and my buprenorphine prescribing physician knows that I'm on hydromorphone. And the sort of key here is, I mean, we don't want to assume that our patients are lying most of the time. Most of the time, I don't think they are. But don't necessarily assume this is correct or that we fully kind of know about the other person's prescribing. Sometimes you are the useful link between the two prescribers. And that's sort of the safest thing for the patient in terms of co-managing two opioid prescriptions. The other sort of consideration, I'm just going to skip over this, is what would you do in this situation if the patient came in and you couldn't reach some of us or either of the prescribers? What are some other potential options, you know, in terms of making that connection between the two prescribers, making sure that everything's kind of okay from both of their perspectives to go ahead with the buprenorphine plus the hydromorphone? And what if it was on the weekend? So some of the suggestions that have come from previous iterations of this course were, you know, you would definitely be within your professional judgment to say, I actually can't fill it today. Let me talk to the docs tomorrow, and then we'll sort of proceed from there. You could also, for example, do a partial fill on the Sunday just for that day, buying you some time to get in touch with the prescribers. So there's different options. There's also potentially other things that could help her pain in the interim, especially if you weren't going to fill it at that moment. And for example, she may ask for the sort of classic, can I have some acetaminophen with codeine from behind the counter? And some patients may not realize, and this is kind of mind-blowing, but at the same time, codeine is kind of a mild opioid that's not really abused that that much compared to some of the higher potency ones. Some patients seemingly don't realize that codeine is an opioid, or that Tylenol 1 contains codeine, which is an opioid. And on the urine drug test that you may remember way back when I showed it to you, codeine is going to show up as morphine. So we can't tell if she used codeine, or if she used heroin, or if she used a huge amount of hydromorphone, which one of the pathways results in some morphine. It's very, very difficult to know exactly what's going on. And as she has take-home doses, that could potentially put those at jeopardy. And she may not sort of realize that that Tylenol 1 has that significance. And this is a opportunity for you as the pharmacist, if you happen to know how this may play out, to give her a little insight into some of the problems that might happen, and to explore with her some of the alternatives. In this case, naproxen by prescription or over the counter might help. If the prescriber of the buprenorphine is involved, sometimes we might elect to just increase that to manage the temporary pain rather than going down the road of adding another opioid. So there's many options, and sometimes not having the connection between the two prescriber doesn't allow sort of the full ramifications of each different scenario to be sort of played out and decided on which might be the best one for that particular situation. I'm just going to skip over this for the sake of time, because we kind of reviewed that already. Just to say a couple of things around the concept of what's called contingency management. And this is essentially the part of the framework of how the carries or the take-home doses are given according to the guidelines that we have in Ontario. So the idea behind contingency management, and it's not just used for opioid carries, it's the idea that programs can build in incentives when patients reach their goal of either reduced use or not using or whatever it may be. And in addition to reaching the goal, they also get some other incentive. It's things, sometimes it's like food vouchers or point systems to get larger value items eventually. In this case, there's an element of this in the way that we give the take-home doses. Partly it's done, of course, for safety, and that's why it's done in a gradual way, but part of it also functions as contingency management, such that when they do well, they meet their goals, they get something that's desirable, which is the freedom of not having to go to the pharmacy every day. So I just wanted to sort of touch on that aspect of the take-home doses that you may not be familiar with, because it's not something that's used a lot in Canada outside of sort of this kind of structure. No one really wants to give money for vouchers anymore for things like this. So in terms of chronic pain, the resources that I could suggest for you are the Canadian guidelines for chronic pain, non-cancer pain, which many of you have probably heard about. You've probably heard about the 90 milligram morphine equivalent limits and things like that. That comes from those guidelines. And then there is also a Health Quality Ontario standard on acute pain prescribing from 2018 that might be helpful. So I'll see if there's any questions with respect to pain before we go on to, I believe it's benzodiazepines next, or pregnancy.
So the only question, what if the GP agrees on a regular prescription of Percocet along with daily dispense of methadone? The two doctors involved agree on both drugs.
I mean, I think if the two doctors agree and the patient wants to do it, I don't see why we wouldn't sort of go ahead. If you had any particular concern they hadn't considered, I think it's your absolute right to raise it. But there are scenarios where that could play out that way. Any others?
Yep, that's the only question.
Okay, so we're going to talk about benzos. So we go back to Julie, and she's stable on her buprenorphine, and gets a prescription for clonazepam 2 milligrams at bedtime. So what concerns might we have? Well, we don't love OAT with benzos. Usually we're trying to get people off their benzos as we're trying to get them onto OAT, and not such great fans of prescribing or initiating benzos to patients who are on OAT for a few reasons. One being that if they had a substance use disorder with respect to opioids, they're definitely at risk for having other substance use disorders with use of other addictive substances, and benzos definitely fall into that category. There is some degree of risk with respect to respiratory depression of having the OAT there and the benzo, although it's certainly higher in the first couple of weeks and not as high sort of in the period after that. And then lastly, which doesn't just apply to patients with addiction, long-term benzo use really has generally fallen out of favor in terms of managing anxiety disorders. We notice that patients who are on benzos long-term really suffer from intradose withdrawal that they misconstrue as anxiety. And a lot of them do a lot better if we can taper them off their benzos once they've been off them for about a couple of months, once all the subacute withdrawal symptoms have resolved. Their anxiety is actually, it's so hard to convince patients to do this, unfortunately, and I understand why, but their anxiety often is really, or their anxiety symptoms are actually withdrawal symptoms masquerading often as anxiety. It's not to say that they have none at baseline, but often it's really not as bad as the anxiety that they have between their doses when they're on a long-term benzo, especially if it's a short-acting one, but even with clonazepam. And the only other thing to say about this, which I think most of you probably remarked as well, is 2 milligrams would be kind of a high starting dose for clonazepam. And I would definitely attempt to speak to whoever prescribed it and just get a sense for the rationale and get a sense for like why 2 milligrams, and see sort of if there might be some alternatives or at least a lower dose. And hopefully she would be on it for a short period of time. So if we have to co-prescribe benzos, and there is a small subset of patients where this might have to happen because of severe concurrent bipolar disorder, for example, or someone who's been on benzos for like 25 years at high doses, whose brain may never kind of get used to not having any benzo on board, or someone with severe trauma history who has, you know, borderline personality disorder. Some situations call for long-term benzos, ideally at the lowest effective dose, ideally prescribed pretty tight dispensing, either daily or weekly, and important to sort of have communication obviously between the prescribers and carefully consider like how stable the patient is if we're going to give these patients carries. So in terms of tapering, there's no one single right way to do this. And so you might see tapers of varying speeds, and that's okay. And it's similar to methadone. Patients may go down for a few steps and sort of stabilize for a bit and sort of keep going. The key is to kind of try to keep them moving in the direction of tapering. I find patients who've been used to taking a benzo to manage any sort of anxiety provoking thing that happens to them, there's always going to be things that happen to all of us that are anxiety provoking at periods of time, and trying to walk them through not always wanting to increase their benzos when that happens and to keep moving forward is definitely not easy. So this, honestly, benzo tapering is way harder, I find, than, for example, methadone tapering. So I think this is our last pool. So patient tapering 1 milligram every month. What do you guys think? Okay. So we're sort of split here between yes and maybe. So both of those answers really are correct. I mean, this is a maybe scenario. I have patients who want to taper very, very slowly. Like I said, if they're continuing to move in the right direction and not always going one step forward and two steps backwards, there's basically no hard and fast rules about how to do this. The one reference that I can sort of point you to that has some kind of recipe is something called the Ashton Manual, ASHTON, by a British psychiatrist who laid out sort of a way of tapering benzos. And so sometimes people will refer to that, but it can definitely be modified. And there's no real hard and fast rule about how to do this. A lot of us will use the long-acting opioids, benzodiazepines. So you'll often see scripts for clonazepam and diazepam as we're tapering. Diazepam is nice in the sense we can go down by 1 milligram. Sometimes the small strengths of the clonazepam becomes a bit limiting in terms of trying to do the taper slowly. The nice thing about clonazepam is its onset of action is a little more gradual than diazepam, so it's a little less reinforcing, but we still use it quite a lot. Methadone tapering. So we talked about sort of patient-centered, slow and steady wins the race kind of approach. Again, there's no recipe. Becomes a bit limiting in terms of trying to do the taper slowly. The nice thing about clonazepam is its onset of action is a little more gradual than diazepam, so it's a little less reinforcing, but we still use it quite a lot. Methadone tapering. So we talked about sort of patient-centered, slow and steady wins the race kind of approach. Again, there's no recipe. A very loose rule is sort of 5 to 10 milligrams every, I would say, couple of weeks or more. It really depends what dose they're at. So dropping by 5 when you're at 120, 80, 70, not such a big deal as when we start to get below 20 or 30, when I find it tends to go better if we start going by 2s or 3s, and then usually 1s or 2s below 10. So that's sort of for a patient who's decided to do it on their own, which is the majority of patients, and we're sort of counseling them as to what may be the least likely to cause them withdrawal symptoms, which of course are triggers for relapse, which we want to avoid. If a patient has to be discharged from the clinic for whatever reason, whether it's behavioral or they're like moving for their job, we can do a much faster taper. It's going to not be as fun and definitely going to cause more withdrawal, but there's an idea behind trying to at least do it gradually rather than have people sort of stop abruptly. And the most important thing at the end or nearing the end of the taper, but honestly, I do this with all my patients now in the age of fentanyl, is talking about overdose, talking about naloxone, making sure they have a naloxone kit, especially when they're completely off the methadone, making sure that they know that their risk of relapse is really, really high, especially if they go back to using the amounts of, let's say they were still concurrently using fentanyl, if they go back to those same quantities, that they are very, very high risk for overdose. So please give naloxone to all your patients. I try to remember to ask all my patients at every visit if I can. So I'll ask if there's any questions around benzos, and then we're going to talk very briefly about pregnancy. Don't hear anything. I'm going to assume that means Cassandra may be tied up or there are no questions.
Oh, sorry.
Yeah, I know. That's okay.
There are no new questions.
Okay, thank you so much. All right, so we're going to just briefly on pregnancy. I apologize that it's so quick. So this is just a different patient to have in your mind. Rebecca, 27, heroin user. These days, heroin and fentanyl are really completely mixed together. So it's very likely that she's being exposed to fentanyl, and you see that in her urine drug test. You see morphine, which is probably coming from some heroin, or who knows, some morphine mixed in with the powder. And as we should be doing with every patient of potential childbearing age, we should be doing a pregnancy test when they first come in and periodically thereafter, and we should be trying to counsel them to consider contraception. I've noticed quite a few pregnancies of late, and not just my patient population, others too, We're not quite sure what's going on, but really trying to do a better job about talking to people about contraception. So opioid withdrawal is something we try to avoid. It's a bit controversial as to how risky it is in pregnancy, but nobody wants to do that study and no one would ever approve it. So we have some kind of older studies that are somewhat helpful, but they're certainly not perfect. And just because of the high risk and the terrible outcomes, or the terrible tragedy of a bad outcome, we really try to avoid anything that could potentially put the mom at risk of miscarriage. So the standard of care really is and has been for quite some time to put pregnant women on opioid agonist treatment. If they absolutely want to detoxify, we certainly can't stop them from doing so. We would want to describe the risks. One of the biggest reasons I find that driving people perhaps away from agonist treatment is neonatal withdrawal, which definitely is a phenomenon. And I often see moms trying to stay on a low dose of OAT because they think that will help the withdrawal of the baby. But they've actually studied this quite extensively, that the dose of OAT does not correlate with withdrawal in baby. What correlates much more is compliance with dosing and other concurrent opioid use. So we really try to say, and of course you can imagine someone who's on a suboptimal dose of OAT is going to be more likely to use other opioids. So those two things don't help us at all with respect to reducing withdrawal in the baby. What we want is mom to be on a dose where she feels comfortable, so she's not feeling like tempted to use other opioids, and that's going to improve our outcomes. Sometimes we have issues with respect to the nausea, vomiting in pregnancy not being a fabulous combination with the nausea of opioids or the nausea related to the tang. Some women seem to do better with apple juice, even though they're both very acidic. Drinking it slowly also definitely helps. So we have quite a lot of studies now with respect to opioid agonist therapy in pregnancy, with respect to reducing the negative outcomes of uncontrolled opioid addiction in pregnancy, and also improving positive outcomes in terms of maternal nutrition, engagement in prenatal care, birth weight, as we talked about, withdrawal in baby, bloodborne infections, sexually transmitted infections, all that kind of stuff. So in an ideal world, and this is by no means, unfortunately, something that every woman in Ontario would have access to, in an ideal world, we would admit these patients to hospital. And in a few centers, this is possible, but in most, it's not. And we're initiating people outpatient. So ideally, we would transition them from whatever they were using to a brief course of morphine, just to help with the transition onto buprenorphine, usually by microdosing. So sometimes the morphine isn't used, sometimes it's straight to microdosing of buprenorphine. Some of the inpatient physicians are actually doing macrodosing of buprenorphine with the idea that you can kind of overcome the precipitated withdrawal and like push through it with doses of like 40, 50, 60, because it's a monitored environment, and then tapering down. But there's no way we would be doing that outpatient. So the outpatient initiations are generally very similar to what we would do for a non-pregnant patient. Pregnancy can be a very motivating time. So often we will see patients who are perhaps struggling to stop using substances be able to make some big changes during their pregnancy. Most patients will end up with children's aid involved at some point in time, because either we may have a concern that we report, or they may be involved at the time of delivery. I put this in there to remind me to let you know that the being on OAT now is seen as a positive thing with respect to children's aid. In the past, I think, due to lack of education, understanding about OAT, there was some negative messages on the behalf of CAS to the pregnant women, that the fact they were on OAT was bad and they shouldn't be using any substances, but now it's considered a medically appropriate treatment, a sign of stability. So it's not something we need to hide from CAS. I will stop pregnancy there. See if there's any questions. That was very brief. There's quite a lot more to know about pregnancy. We have a few physicians in the province who sort of practice exclusively in this area, who are sort of experts to whom I would go with some of my pregnancy related questions.
So there were no questions posted, but just wondering if you can comment, should we still be trying to get patients who are on Suboxone switched to Subutex, or would you say?
Oh, yeah, that's a good thing. And I want to see something about split doses too. So thank you for that. So the expert consensus right now is no, we're not switching to Subutex anymore. The idea behind it is it's a huge laborious process that causes lots of anxiety and practical destabilization if we stop Suboxone and there's a delay in getting the Subutex, which there often is. And pharmacologically, the naloxone, as I said, is not absorbed sublingually. Even if it was absorbed, it's category C, which is unknown, which we don't love giving pregnant people category C medications, of course, but this one for practical purposes is really as if it's not even there. So the expert consensus was that the risks of trying to go through the whole process and the destabilization that came with trying to get people onto Subutex is not at all outweighed by the very, very tiny theoretical risk of the naloxone and the Suboxone or the generic. So we just continually stay the course. We don't try and get them on a product anymore like we used to. And just, I promised to say something about missed doses and I didn't, and I apologize. We, as you know, pregnant women's blood volume increases considerably, especially towards the third trimester. And so it is very common for us to have to increase and split doses of both medications during pregnancy. BID, TID, it depends a little bit on the individual woman. And within the first few months after delivery, of course, the blood volume does reduce, and we often are having to reduce the doses back. And usually we would be reducing it back to once daily, just because that's sort of the standard way to prescribe, absent any metabolic reasons to split the dose or any pain-related reasons to split the dose. So you'll see dose go up, often be split, and then within the first few months after delivery come back down. Was there anything that just popped up there?
Just out of curiosity, a comment, just out of curiosity, what do we give neonates who exhibit withdrawal symptoms?
So in the past, morphine, like small aliquots based on there's a scoring system that they use in the NICU for neonatal withdrawal. And so they would give little aliquots of morphine, but I understand that more recently they've been studying actually giving buprenorphine for the treatment of neonatal withdrawal. The other thing to say about neonatal withdrawal is there's some of the more progressive maternity programs that rather than take all the babies to the NICU by kind of rule, they'll take the sickest babies to the NICU, the ones who need respiratory support or maybe a risk of seizures, things like that. So that's the minority, but there are definitely ones who need that support. But the ones who are less acute do much better if they can be with mom in the room for some of the physical soothing. That definitely helps the withdrawal symptoms. And of course, the nurses would still be doing the scoring and still be giving medication if need be. But the outcomes, and this is mostly Vancouver's group, the outcomes have been far superior having the babies who are safe enough to room in than having just shipping them all off to the NICU as kind of routine. So that's something nice, non-pharmacological, pretty easy to do. Takes some nursing readjustments, of course. But with really nice outcomes. So that's just another thing to know about pregnancy. So I'm going to move to harm reduction, unless there's one last pregnancy related question.
No additional.
Okay. So harm reduction, we've touched on naloxone a few times. Harm reduction mostly focuses on reducing the medical complications of injection drug use, and of course overdose as well. So we're looking at overdose, skin, soft tissue infections, brains, spinal fluid, these terrible infections that you get from intravenous drug use. And then of course the bloodborne pathogens. But another sort of aspect of harm reduction is really the reduction in involvement in crime or violent activities that may also, of course, be harmful to our patients. So in terms of looking at harm reduction on the spectrum of options for patients, it should be really provided in tandem with other treatment options, abstinence as a possible goal if the patient wants that. It sort of should be integrated within the spectrum of addiction treatment and not just offered as a standalone. And sometimes that's some of the criticisms with respect to harm reduction, is let's make sure that it's really tied with a way for the patient to connect to other treatment options if they would like to at some course sort of in their journey of being involved in harm reduction. And the main criticism, which has really been quite debunked in a lot of research, is, well, if we make something safer, more people are going to do it, and it's still not completely safe. So look at some of the research studies related to that to help reassure you that that's actually not the case. So this is our last case in a fairly dramatic picture of someone who is injecting. And so this is a patient that you may see come into your pharmacy for reasons and complications related to their IV drug use, such as cellulitis, abscesses. Maybe they're coming for their antibiotics. Maybe you're not even involved in their opioid use disorder treatment, but you're interacting with them. And to sort of think about, how can we help this patient? Maybe they're not ready to be on OAT. We could certainly provide them some information on it and like where they could go to a clinic. But what else could we do for this patient aside from just fill his antibiotic prescription? And this is where your role in terms of providing some of the harm reduction tools comes into play. So many of you, I'm sure, are familiar with the naloxone kits. So this is one of the intranasal ones. And I'm very happy that almost all the pharmacies that I work with that do OET are also able to give this to the patient. Sometimes I write it on the script in case the patient forgets to ask for it. And sort of the more overdose kits we have out there, the better, because sometimes when people are overdosing on the new fentanyl powder, we need more than one kit to reverse that overdose. Some other supplies that some pharmacies may be giving out include syringes, which has been legal for some time now. Other supplies in terms of preparing substances for injection, such as sterile cookers, water, the matches, as you see there, alcohol swabs, things beyond just the needles. And just to give us a little bit of history, I think many people are aware that we've had safe injection or needle exchange programs for quite some time in the major centers of Canada since the late 80s. That was really in response to HIV transmission and trying to reduce that. And they've really expanded a lot over the time since then to be in many different communities. The legal hurdles in terms of distributing needles were overcome quite some time ago. But we still do have quite a burden of bloodborne pathogens, particularly hepatitis C, in our population of people who inject drugs, which is the PWID. So we're still, although there's a treatment for hep C, it's very expensive. It is covered and it's much better tolerated than it was in the past, which is great, but it's still on a societal level, much more cost effective for us to try and prevent people from getting hep C than to keep treating them and retreating them for contracting it. Hepatitis C is more virulent than HIV. And so it's the one that's more likely to be passed if people are sharing equipment than HIV, which is still a concern. But we're really trying to prevent rather than having to treat, particularly the hep C. In terms of needle and syringe programs, the evidence really is there in terms of reducing the transmission, reducing the amount of needle sharing or reusing. Using is risk for septicemia, blood infections, and whatnot. The concern initially was, well, if we're giving out lots of needles and they become kind of like whatever, people are going to discard them and they're going to be all over the place. But Insight in Vancouver really looked at that in order to sort of mitigate the community concerns and found that they were actually getting more needles back than they were giving out, which was interesting. And if we can engage someone in a program where they're getting safe supplies, that's an opportunity to get them into treatment. And also cost effectiveness has been proven. So you can imagine you give someone a clean needle, we don't have to give them a $40,000 hep C treatment or admit them to hospital for 21 days to treat their, whatever septic infection they may have from the injection use.